Hello everyone, how are you all? Welcome to our session of MSc Roleplay. So we're going to start just now. Okay, so have you guys finished the MSc? The class that we have taken in our, I think it was on 7th of March, right? So about a week ago, I think that you guys have understood the basic of psychiatry MSc, which is really important for your exam. So we're going to start some of the role play related to that class. And this is how usually we take classes in our course as well. So we finish a cluster and then we do some role play on that particular cluster. And those cases are really important for your exam as well. So we'll start doing the role play as much as we can within the time limit. So who wants to do the first role play? I can see Dr. Shirisha, you wanted to do the role play first. So we can start with you if you want. And then Dr. Parla, Dr. Tarinda. So we can start with you guys. It's good that we are having a lot of interested candidates. Sometimes it becomes really hard to get someone to do the role play in our class also. So it's good that we are getting you at the moment. All right, so I'll just unmute you, Dr. Shirisha. So just before starting, those who are in the Facebook Live, normally we don't take any classes on live Facebook session. It's just for this free 2 weeks session, we are taking it, but always it will be on the Zoom in our course. So if you guys are in the Facebook, you will not be able to do role play with me because it doesn't work in that way. So if you still want to do some role play in our today's class, please come to the Zoom. Already the Zoom ID and password and also the link has been provided in various posts. So you can go through that and you can come to the Zoom session and you can also join the role play if you want. But if you just want to hear and watch, that's also fine. All right, Dr. Shirsha, so let me unmute you. Dr. Shirisha, can you hear me?
Yeah, yes, doctor.
Good. All right. Just give me 1 minute to give you the case. Okay, we'll start with the normal one, the initial one that we have been discussing in our last class. Okay, and then we'll go through the more important ones. So this is your case, Dr. Shirisha. You will get 1 minute time in the outside, but normally for in the exam you know that you get 2 minutes outside and 8 minutes inside. But when we do role play, it's always better to make sure that you get 1 minute in the outside and 7 minutes in the inside, so that in the exam you are well prepared and your time management is perfect. So always when you are also doing role play with your partner, keep it as a 1 minute outside and 7 minutes inside. Okay, so let's start. Dr. Shirisha, your 1 minute has started just now. All right. Hi, doctor. So this is your patient. Your patient name is Sam. You can start.
Hi, Sam. I'm Dr. Sirisha and I'll be taking care of you today. How can I help you, Sam?
It's- I don't need any help, doctor. I'm okay.
So, Sam, whatever we discuss will be confidential unless it is harmful to you or others. Okay, you can feel free to discuss with me.
Yeah, yeah, whatever.
Can I know is anything bothering you? And can I know how is your mood nowadays, Sam?
I know. I don't know, doctor. I I'm a murderer, and
Okay.
I just killed a cat
Mhm.
on my operation table.
Mhm. Okay.
I'm a murderer. Just give me to the police and just give me arrested. I don't want to live this life anymore.
Sam, I can see that you are very much in distress. Uh, you have done nothing wrong, Sam, and we are here to help you out, okay? I would like to ask you questions. Can you know how is your mood nowadays? Are you feeling? Mhm.
Um, I don't know. I'm feeling really bad this time. It's you don't know,
All right.
doctor. You can't know.
So, Sam, once again, I want to say you that you can share me whatever is bothering you so that we would help you further. Okay, Sam, we are here with you throughout your journey. Okay. And so, Sam, can I know how is your sleep nowadays?
I can't sleep. I just see that cat. I can see that poor little cat in front of my eye all the time.
Mhm.
I can't sleep anymore.
Okay. Do you have any early morning awakenings or do you take long time to sleep?
I can't sleep at all, and all I can think about is that cat.
All right. And how is your appetite? Do you have any changes in your weight?
I don't know.
All right. And sometimes people, when they are stressed out, they may think to harm themselves or others. Do you have any such thoughts by any chance?
I don't want this life anymore. I just want to kill myself. That's all I want. This is what is the point of life if I'm a doctor and I just kill my patient?
And Sam, do you have any organized plans?
I don't know. I just want to use anything that I can find in front and I kill my life.
And did you had any previous attempts?
No,
Mm, all right. And can you know how is your concentration?
I can't concentrate on anything. I just
Okay.
want to
And, mhm.
end this stupid life.
Okay, very sorry that Sam. And can you know how is your energy levels and do you feel guilty?
Yeah, yeah, I know. I killed that cat, doctor. I killed him in front of my eye.
Mm. So Sam, can you know, do you have any slowness of your movements? Did you observe?
I I don't know, doctor.
Okay. And are you enjoying things that you previously used to enjoy?
I don't enjoy anything. I just want to end this thing.
Mm-hmm. All right. And Sam, can I know how is your home? How is your home situation?
My wife is struggling with all these things, and I,
Mm-hmm.
I just don't want to involve anyone in this shitty life. Just let me end this.
And Sam, sometimes I am going to ask some strange questions. It may look weird, but these are just screening questions, and we are not going to judge you, Sam. Okay. And do you have any passing thoughts of like you can see or hear things that others don't?
I don't know. I see the cat all the time in front of my eyes.
Mm-hmm. Mm, right. And can you hear its voices or do you feel it?
No,
No. All right. And uh, do you some feel that someone is trying to harm you or someone is trying to kill you?
no. I just want
No.
to kill myself. That's all.
Mhm. And do you think that people are talking about you or your thoughts are being broadcasted on television?
Yeah, all the nurses and everyone in the street is just calling me that I'm the murderer, and
Mhm.
and they hate me. They hate me because I killed a cat.
All right. And okay. And do you think that you need any medical help, Sam?
No, I don't need anyone else. I just want to end this.
Mm-hmm. And can I know whom you're talking to and where you are exactly?
Yeah, I'm at the hospital and I'm talking with you.
Mm-hmm. And can I know, suppose there is a fire, what do you do?
I'll just stay here.
Okay. And so, Sam, can you said that your wife is there, and do you have proper support from your family members or friends?
I don't want anything, doctor.
Mm-hmm.
They are all trying to get me better, but I don't want. I just want to end this.
All right.
This life has no meaning.
Mm-hmm. And so, Sam, do you smoke or drink alcohol?
No,
Okay. Do you take any recreational drugs?
no,
Okay. Do you take any medications?
no,
Okay. Did you had any previous history of any medical or mental illness?
no,
Okay. Any family history of significant any medical or mental illness?
no,
All right. And did you had any head injury and flu-like illness recently, Sam?
no,
Okay. And any weather preferences?
no,
Okay. Anything else you want to share with me, Sam?
nothing, doctor. I just want to end this.
Okay. All right. And Sam, are you feeling guilty even after reassurance from your family members?
Uh-huh.
Okay. All right.
No worries at all, Dr. Shivisha. You did really great. Your question, asking the questions is very, very good. But important thing is that it's just a performing the MSc, which means that you don't need to ask like all these questions. Remember the time we took the class last week, I told
Mhm.
that what if if your task is to perform MSc, you can just stick to your task, which means that you will just ask the aseptic J3R. Now, if you would ask it, then you already got all the information that you need to perform or to present the MSc to the examiner, right? So all the aseptic J3R only that is needed. You don't need to even ask any depression questions more than what is needed in the MSc aseptic J3R. You
Okay.
already know.
Mhm.
Sorry, I think there is some noise coming up. Is it from your background, doctor?
Yeah. Yes.
Okay, no worries. I'll
Yeah.
just unmute you for the moment. Okay. Sorry, mute you for the moment. Thanks. All right. So what I was telling to Dr. Shirisha is that if your task is to perform mental status examination, which is the MSc we are talking about, you don't need to ask all these questions. If this task was that take a psychosocial history, then you should ask all the questions that you asked. Like you will ask about, because you already know that this is a depression case, so you want to ask all the depression related questions, which is your M Sage caps. Now, M Sage caps is important. If your task is like taking a psychosocial history, then you can ask it. Or if your another task is to give the diagnosis and differentials, then all these questions will be relevant things to do. But if your task is performing the MSc, you will just stick to the first giving the confidentiality, then what else? Aseptic J3R, which means that you want to know about the just mood, sleep, and appetite, which is even not very important. You want to know about any hallucination, any delusion. You want to know about the insight, cognition, judgment. That's only thing that you want to know. You can ask couple of questions just to wrap up your history, which means that you can ask any past medical history. You can ask about sadma. You can ask one question about the family situation, and then just stop it. It's just closing the history, which is even not very much relevant to MSc. And presenting MSc to the examiner, keep at least 2 minutes in your hand to present it, because this is very, very important. Okay. So what are the positive findings in here you guys have got? Dr. Parla, it's M side caps. It's actually a part of depression questions, which we will discuss in our later classes, not today. So what are the positive points, Dr. Shirisha, and also all of you who are listening? What do you think the positive findings in terms of aseptic J3R? So obviously, for the purpose of this session, you will not see the appearance. So forget about the appearance part. You can use anything that you want in the appearance. But after appearance, then your speech. How was the speech? Speech was slow, you can say, and there was some taking pause in between, right? And you can also say monotonous. It's like a part of monotonous, or sometimes I was spontaneous. Okay, so that's your speech. After that, what else? Emotion. What was the mood of the patient? Mood was very low or not good. And obviously, the effect that you have observed was congruent to the mood. Then perception. Was there any perception positive in here? What was the perception? Visual hallucination. Very good. So I kept saying that I can see the cat all the time. So that's a visual hallucination. Now it's, remember one thing, just because it's a most likely a depression case, you cannot get visual hallucination. That's not right. People who are having severe depression, they can have psychosis associated with it. So always like keep your mind broad. Anything can be positive. Okay, so visual hallucination was positive here, but there was no auditory hallucination or tactile hallucination. After perception, thought form. Thought form, you can say it was linear. Okay, thought content. Delusion. What was the delusion in here? In here, the delusion of guilt was positive. Right, good. And then what? Insight was poor, cognition was okay, and judgment was poor as well. And how about the 3R? Is this patient high risk? Oh, there was another thing positive in the delusion. Sorry. If you guys were very careful, you will notice that, yes, delusion of reference. I said one time that people are talking about me, or people are saying, and the nurses are saying that I am a murderer. What is that? That's your delusion of reference. So there was mainly two delusion, delusion of guilt and delusion of reference. Very, very good. Insight was poor, judgment was poor, cognition was all right. And in terms of 3R, patient is a high risk because having active hallucination, delusion, and also suicidal thoughts. The rapport was good, so I was able to maintain a good rapport with the patient. And then, in terms of reliability, is this history reliable or not? Now, no, you can say that this is like, it's totally depend. Like in here, like if you say that the history was not reliable, that's also fine because this patient has some associated psychotic features. So anyone having a psychotic features, their history is not reliable. So you should take a collateral history from the neighbors, partners, or anyone who is there. Okay, so that's the thing. It's not very reliable. That's the thing, because if it was only depression findings, then you can say that yes, in here the history was reliable. No, the judgment was poor. That's why I say that the judgment is poor, because Dr. Lin, if patients say I would stay even if there is fire in this room, that means patient's judgment is poor. So, Dr. Taba Jawad, what is meant by linear thought form? Linear thought form, that if someone is responding to your questions appropriately without having any loosening of association, tangentiality, circumstantiality, that means that patient's thought form is linear. Even a psychotic patient's thought form can be linear if they respond to your questions appropriately. Cool. So that's one of the MSc case, which is really important. Now you know that Dr. Shirisha, I know that you knew everything that all other people are saying here. You knew everything is because what happens that in front of the role player, it becomes really, really hard because you don't know what is I am saying about. And in the exam also it will be the same case. Anything they can say. And you have to be prepared that what is the format in your head. You just need to stick to the format and finish it in time. That's the main motto. So for MEC case, always write aseptic J3R in your paper so that you don't go to and fro. It's really important. I know what happens that everyone knows the format, everyone knows how to ask a psychosocial history or MSc, but in the exam, because the role player are very, very good actor, even I am not like 50% good actor than them. So they are really, really good actor and they are doing it as a professional way. Okay, so they are really good in these things. That's why they are in the exam. So in front of them, you might feel really confused or perplexed. But if you just make sure that you know the format and you stick to the format, then they cannot fail you anyway. Okay, because you stick to the task, you asked the appropriate questions, you finished all the key steps, and then you presented the MSc as a format. So then you should obviously pass. Okay. So make sure you guys always follow the format. That's why this is very important to stick to the cluster wise format. Okay. Because in the exam, you guys can get really, really confused. It's just because we are not used to that type of stress level. Someone's video is on. Please stop your video. I will just stop it. That's fine. So how we will assess thought content? So thought content is your delusion, okay? And thought form is your linear thought form, circumstantiality, tangentiality, okay? Like that. We already discussed all these MSc things, Dr. Taiba. If you haven't uh, joined in our previous session, make sure that you do that first because it's very, very important to understand all these terms. Then it will be really easier. Okay, so make sure you all, like any of you who hasn't done our first session on MSc, you should obviously do that before doing the role play. All right. So you took the for the history, you took 7 minutes. And the first session is given as a recording in our new Facebook group who are mainly interested for our next 5 months online course. So there is a Facebook group link in your first aid AMC clinical group. If you just scroll down anywhere in the post in the previous 2 or 3 days, you should get the link of that group. All right, most of you are already in that group. So if you don't know the link, please scroll the group. You will find the link where we have already provided the recording of the previous session. Okay, Dr. Madiha. Who wants to do the next role play? All right. Uh, let's start with Dr. Parla. So Dr. Parla, I will just on your microphone. Can you hear me, doctor?
Yes, hi, thank you.
No worries. Okay. And then we will go for Dr. Lane, and also I can see some of the other interested candidates are here. The name of the group is First Aid AMC Clinical. Dr. Madiha. Give me 1 minute, Dr. Parla. I'll give you the case.
Okay, thank you.
No worries at all. Okay, let's see what I can give to you. All right, so you know that you will get 1 minute time for reading and preparing this case, and then you will get 7 minute insight. Okay, so let's start. So this is your case. All right, Dr. Parla, I'm just giving you a visual view of your role player. So your role player is very anxious looking and having frequent fidgeting of the hand. So this is a part of your MSc. So just keep it in mind. Okay.
Yep.
And we will start just now.
What's
Hi,
his name?
doctor.
Sorry, what's
Yes.
the
Hi,
name of
doc.
the patient?
Hi, doctor. This is your patient. Your patient name is John. You can start.
Thank you. Hi, John. My name is Dr. Perla. How can I help you today?
Uh, Doctor, thank you so much for giving me your time. Um, I don't know, doctor. I'm really feeling like very unusual thoughts in my head at the moment, and I just want to get rid of these thoughts. It's killing me inside. I know this is really stupid, but I can't stop thinking about it. It's really stupid of me. I don't know why these thoughts is coming into my mind every now and then.
I understand, John. Just before we continue, I just want to let you know that everything we talk about now stays confidential between you and I, unless it's harmful to you or to others. So you can trust me, and everything we say is going to stay between us. I just want to ask you a couple of questions. How are you feeling nowadays?
I'm feeling stupid, and I'm feeling like I'm getting mad. I think because this thinking that's coming in my mind is not a it's not it's not good. It's real bad. I don't know
What
why this is happening to me.
what are you thinking about exactly?
How I can say, doctor, is so bad. Please don't get misunderstood me. Actually, this thinking. I'm thinking that my mom is having sexual relationship with my uncle. It's so gross, I know, but I can't stop thinking about it. It's really gross.
No, it's okay. I understand your concerns. So you're feeling angry and you're feeling stupid. Do you feel like you have a low mood as well?
Not really, but I
Okay.
feel really bad. Yeah.
How about your sleep? Do you have any sleeping problems?
No, not much.
And your appetite? How's your appetite these days? Are you eating well?
I I actually don't eat well because this thinking are making me crazy.
Mm-hmm. So you feel like you lost weight these days?
No, I don't think so.
Okay. How about your life? Do you feel like life is worth living, or do you have any passing thoughts of harming yourself or others?
No, I think life is worth living.
Okay, that's good. That's good. Now, I have to ask you a couple of questions that might seem a bit strange or odd to you, but these are part of my exam. And just, yeah, if you can answer these questions as honest as you can.
Yeah.
John, do you feel or see or hear things that others don't?
No, why I would do that, doctor? I'm not mad. I can assure you that it's just
No,
these thoughts going
I
on.
understand. Yeah, it's just part of our exam. We have to ask these questions. Don't worry.
Okay.
How about your thinking? Do you feel like someone is spying on you, trying to harm you?
No, I don't think so.
Do you have any thinking of guilt, like you feel guilty
No,
and you feel like someone's controlling your thoughts or broadcasting them?
not really.
Okay. Do you think you need medical help with your issue today?
Yeah, I think so. I really need help because this thinking is really killing me. I just want to get rid of these thoughts.
I understand. I hope we can help you better today. I have a question. If there was a fire in this room, what would you do?
I would run away.
Okay, good. And where are we now?
We are in the hospital.
And what's the date and the time?
Oh, I don't know. I think it's Sunday, 14th of March, right?
Yes. And who are you speaking to now?
The doctor?
Yes. Also, do you feel like you have enough support at home from your mom, from your uncle?
Yeah, my mom is like, she's really caring about me, but it's really stupid of me that why I'm thinking this thing.
And what's your home situation? Do you live with your mother?
Yeah, I do.
Okay. And what about your smoking? Do you smoke? Do you drink alcohol?
No,
Do you have any past medical history? Do you take any medications?
no, actually, I was really healthy before that.
Okay, yes. And do you have any allergies?
No,
And do you have any past history of mental illnesses with yourself or in the family?
no,
Okay. Okay. Thank you, John. Thank you for answering these questions.
thank you.
Now, doctor, do I have to like wrap it up
Yes,
or should I?
present the MSc.
Oh,
Present
okay.
MSc to me. Yeah.
Yeah, okay. So I saw a patient just now, John. He appeared to be well groomed, um, and he was dressed appropriate to the weather. He was cooperative with me. I'm not sure about his eye contact. He had frequent fidgeting, and he felt a bit restless. And in terms of speech, he had normal rate, volume, and tone. And his mood was congruent with his affect. And his perception was normal. There was no hallucinations. And his thought form was linear. And in terms of thought content, he did not have any delusions or obsessions. No, maybe obsessions. I'm not sure if that thought that he had was an obsession or an overvalued idea, to be honest. That's where I'm a bit confused. In terms of cognition, he was oriented to time, place, and person, and he had good insight and good judgment. And I consider the patient to be mild to moderate risk. Because he doesn't have any active hallucinations or delusions. He does not have any suicide attempt. And he has good support from his family, and he does not use any illicit drugs. In terms of rapport, I think I had good rapport with the patient, and the history was reliable.
Time up. Thank you, Dr. Parla. It was really nice. I really appreciate how you did this case. Now, I know that why you get confused with that overvalued ideas and
Mhm.
is it abnormal thoughts. Now, always like in this case, like if you think that, well, is it a overvalued ideas or is it some kind of delusional thoughts? So you can always ask the patient that, well, how do you think about your thoughts? Do you think that it can be true? So
Mhm.
if you ask the patient that, do you think it can be true? Then patient will say, no, doctor, I know that this is not true. It's just stupid thoughts coming up in my mind. And I know that this cannot be true. So this is how you differentiate between these two. If it was a delusional thoughts, then patient will say, no, I know that this is exactly what is happening. Okay, and they
Okay.
believe it. So
Yeah.
that's the difference between an overvalued ideas and this kind of like delusional thoughts. Now,
Mhm.
obviously, because you know that just by looking at this case, you will understand that this case is actually a part of obsessive compulsive disorder. Although we don't need to go into that, we don't need to ask any particular question to diagnose that, but obviously you want to at least you want to know that what is the compulsion. So what happens when these thoughts come into your mind? You just
Mhm.
want to know that, because this is really important, because you are taking history from this patient, and you know that this patient having these obsessional thoughts in his mind. So obviously we want to know that is there any compulsion associated with it or not. Then
Mhm.
you can be more sure that, well, the thought content has having this kind of obsessional thoughts and also some compulsive behavior. So if you would ask me that, well, what happens when these thoughts come into your mind? So I would say I just need to go, or I just need to move around the room a couple of times to get rid of these thoughts. You can then be sure that, well, this is an obsessional thoughts and this is a part of overvalued ideas. Okay, so always do that. If you are not sure that what it is, ask questions to find it out, and that's totally appropriate.
Okay. I just have one question, doctor. So you're saying that the overvalued idea is part of his obsession?
Yeah.
Okay.
So
Okay.
overvalue, like in this case, what happens that usually, remember that thought content has couple of subdivisions. One of them is your all the delusional questions that you ask to the patient. The second one is overvalued ideas, which is like mainly overvalued ideas are part of anorexia nervosa, bulimia nervosa, obsessive compulsive disorders, or even body dysmorphic disorders. So
Mhm.
these are part of like overvalued ideas. Now, I would rather not say that this is a overvalued ideas. Rather, I would definitely say that this is an obsessive compulsive behavior.
Mhm.
Okay, because overvalued ideas is mainly like when you think something extra. Like if you are a fit person and you think that you are overweight and you need to lose body weight, that means you are thinking excess, and that's your overvalued ideas. But obsessional thoughts is a little different, I would say, from your overvalued ideas. Keep it as an obsession part. Like if you think, if you keep thought content, then keep a three subdivision into it. One of them will be delusions, which is mainly your RC GGP questions.
Yes.
Then the next one is the overvalued ideas. So anorexia nervosa, bulimia nervosa cases do not come from those overvalued ideas, but anytime it can come. Then the third one, keep it as a OCD or obsessional and compulsive behaviors. Okay, in that way it will be easier. And always in this case, you have to say that in terms of thought content, my patient is having obsessional thoughts that his mom is having sexual relationship with his uncle and also having some compulsive behavior. So in this way, you will say that.
Doctor,
Okay.
should I have asked like more details, like why do you think that, or did you see something? Like, should I go with it or no?
No, you don't need to. You don't need to go into that. That have you seen any time? It's just you can ask that. Do you really believe that your mom is having sexual relationship with his uncle, or is it just your thought? So you just need to find out that what is the level of this belief. Is it just a thought, or is it like patient actually believes that they are having sexual relationship?
Okay.
So you don't need to go into detail that have you ever seen or not, but you should ask at least the compulsive behavior. That's really important.
Okay.
All right. And also you did really great, Dr. Parla. And what you can add in here, because you will get a lot of time in this case, mm, emotion. In the emotion, you did not say what actually I said about my emotion. So always in terms of emotion, patient's emotion was like very bad or stupid, something like that. I kept saying that I'm feeling very bad, I'm feeling very stupid. So you should use the patient's terms when you say the emotion. And then you say the emotion, the mood that I have observed that was congruent, or the affect that I have observed that was congruent with the patient's mood.
Oh, okay. Yeah. Thank you.
Okay. And also sometimes use some of the negative findings, because you will have some time in this case. It's not like too much difficult case. So you will get a lot of time. So just say some of the negative findings, that thought form was linear, but there was no loosening of association or disorganized thoughts or anything. Like you can say no tangentiality, circumstantiality, or flight of ideas.
Mm-hmm.
So
Okay.
negative things are also a good addition when you present an MSc to the examiner. It
Okay.
shows that you know what you are talking about, and also the examiner or the invigilator nowadays, they will know about it.
Okay.
Okay, good. That's great. Thank you so much, Dr. Parla. You did really good.
Thank you, doctor.
No worries. Thank you. Sorry for that. All right. So I'll just mute you, Dr. Parla. Now we are going to do one of the video cases. Who wants to do the video case? Yes, Dr. Lin, please come online. I will just unmute you.
Hi, Dr. Asham.
Hi. Yes. Hello, doctor. So this will
Hi,
be a
yeah.
video case, which means that
Yes.
I'll show you a video of a doctor and a psychiatric patient's interview. Usually in the
Yeah.
exam, they will provide it in a big screen, and you need to just you need to watch it for 4 or 5 minutes, and then you need to present MSc to the examiner on whatever you have observed in the video. Okay,
Okay. Yeah.
let me find out the video. Just give me 1 minute.
Yeah, sure.
So I will just start the video. Okay. So in here, your task will be watch the video for, usually they will show you for 4 or 5 minutes, and I will keep 2 minutes to present the MSc at the end. Okay.
Yes. Okay. Thank you.
So let's start. Oh, just 1 second. All right. You ready?
Yes, I do.
All right. So let's start. Oh, why it's coming in this way? Good.
Hi Andy, do you want to come on in and have a seat? I'm Dr. Taylor, I'm the on-call psychiatrist for this afternoon. I got a call this morning from your family doctor because I think you went to see him this morning along with your mum, and I gather that things have been a little bit difficult for you. You've had some rather distressing experiences. So I think your doctor thought it might be helpful for us to have a bit of a discussion about that to see if I could help. Would that be all right with you?
No, it's fine.
Would it be all right, Andy, for you to tell me a little bit about what's been going on?
Well, you're going to think it sounds stupid, but my housemates are working for MI5,
Right.
and they're doing stuff to my brain.
Okay.
They're out to get me.
Okay. That must be very difficult for you.
Yeah.
How long has this been going on for, Andy?
About 2 months.
Right. And how did you first work out that this is what was happening?
I came home one time and had moved the TV to the side of the room, and
Right.
I knew then
And what was it that you knew at that moment?
that that they were for MI5.
Right. Okay. Okay. So it's been going on a couple of months.
Yeah, this new lecturer started at
Right.
uni, and he works for MI5. and
Right.
He basically drafted me out, turned them
Okay.
against me.
Okay. Okay. Now I've noticed a couple of times while we've been talking that you've sort of looked round you into the room as if you're checking for something. Could I ask you what's happening at those times?
Oh, I can hear him talking about me.
Right. Who is it you can hear?
My housemates.
Right. So that you recognise it's their voices?
Yeah, I can hear them all the time.
Right. How many voices can you hear, Andy?
3. There's 3 of them.
Okay. And do they sound real, like my voice sounds talking to you now?
Yeah, it's odd. It's like I can hear them when they're not here.
Right. So what they're not when they're not in the house with you?
Yeah, it's like they're in the other room or something.
Okay. Okay. And can you hear what they're actually saying?
Yeah, they're talking about me.
Right. Okay.
They're always talking about me.
Okay.
They're always commenting on everything that I'm doing.
Right. Can you give me an example of what they would say?
Well, like if I'm packing my bag to go to uni or something,
Mhm.
they'll comment on that, like he's
Right.
left the house.
Okay. Okay.
You know.
Anything else? Do they ever talk to each other, perhaps about you?
Yeah, that's what they do. I mean, and now they know. They've sort of twigged that I know about them now,
Right.
and they're saying like I'm making trouble,
Okay.
and that they're gonna sort me out.
Okay. Okay. What about actually talking directly to you in the way that I'm talking to you now? Does that ever happen, Andy?
No.
Okay. So you've been hearing the voices of your housemates. Have there been any other changes? Have there been any changes perhaps to the way you're thinking? Sometimes people tell us that their thinking changes in some way. So, for example, they might feel that they're getting thoughts put into their head that aren't their own. Have you had any experiences like that?
Yeah. I do think things that aren't me. Like
Okay.
they're putting stuff in my brain. It's not me. I'm not thinking.
So different thoughts in your brain.
Yeah, that's
right.
like it's stupid stuff as well. It's like the other day I suddenly just started thinking about some woman in Coronation Street. I don't watch any of that crap.
Right. It's not your kind of thing
not-
normally. Right.
They're not my thoughts.
Right. Okay. And do you have any idea how that's happening, or who's responsible?
It's MI5. It's this chip they've put in my head,
Right. Okay.
and I can feel it all the
Okay.
time.
Okay. So you're getting thoughts put into your brain that aren't your own. What about a different sort of experience? What about the experience that somehow other people are able to know what you're thinking, even though you haven't actually told them?
No.
Nothing like that.
They're just putting stuff in my head.
Just putting stuff. And can I just check, Andy, as well, that you're not getting the experience when your thoughts just stop altogether, like you have no thoughts left?
No. If anything, there's too much in there. I wish I
Right.
could unplug it.
Okay. Okay.
Just get this thing out of my head.
Right. And you mentioned this chip or this device in your brain. Do you want to tell me a bit more about that?
Well, it's a tracking device, so they
Right.
know where I am at all times, and that I can feel it moving around, like
Right.
rotating
So you can
around.
feel the physical sensation in your
Yeah.
brain. Okay. Okay. That must be very difficult for you.
I don't know why they're doing. There's
Okay.
nothing wrong.
Okay. Can I just check, are there any problems, Andy, with the rest of your body? Any changes in sensation or any bits that feel different in any way?
No, I feel fine. I'm not.
Right.
I'm not ill or anything. I
Okay.
just want this thing out of my head.
Okay. I mean, it sounds like a very difficult time for you. Can I ask you, Andy, how are you coping with all this? How's it affecting you?
Well, I'm not really leaving my room much, and sort of have to wait till they go out to go down and get some food. But they've been doing stuff to my food now, so
Okay. What do you think's happening to your food?
they're poisoning it.
Right. Okay. Are you actually eating much at the moment?
All right, doctor. So you'll get 2 minute time to present your MSc.
Yes.
So
Yeah. Yeah. Thank you, Dr. Ashan. So today I assessed the patient name. I couldn't remember names. 21 years old university student. Come because the refer from the GP, and from the minimal mental state examination on appearance, the patient dressed well and also well groomed, and in behavior he's quite coordinated well, and he maintained the eye contact sometime, and all the times lose the eye contact, so is on and off, and his behavior is quite normal, and his speed is a normal rate, rhythm, and also the tone, also the normal volume. The emotion has not been assessed, but from what I observed, he has a quite a normal emotion. And in the perception, he has an auditory hallucination when he heard that his housemate talking about him with about three voices, no comment, no auditory comment. And the talk form is linear and well controlled manner. And in the talk content, the patient have the talk of reference, delusion of reference when he think that's people talking about him, and also have the persecution, also the paranoid talk delusion when he think that there's poison food, and also there's tracking device is brand, and also have the insertion of the talks when he thinks ML5 put chip in his head. There's no obsessional talk, and the insight has not been assessed. Also, the cognition and adjustment has not been assessed. So for the rapport, I think the examiner had created a good rapport to him. The story, I couldn't say is reliable or not because I don't know about the insights not being assessed. About the risk, and the suicide risk had not been assessed well, so I couldn't. The risk is could not be assessed at the moment. So he possibly have high risk because he has the hallucination, active hallucination. Thank you.
all right. Thank you, Dr. Leon. It was really good, actually, I would say. You got most of the important finding. Now, let's say that what else we can add in here. Anyone else can tell me there was one thing, I think, one of the positive finding which was missed. What was that? Suicide has not been assessed, Dr. Cookie. Tactile hallucination, Dr. Francie, right? So, yep, tactile hallucination was important. Why? Because patient thought that there is a physical sensation of the chip, right? So that says that patient having a tactile hallucination. If someone feels or someone thinks that there is a physical sensation of insect crawling on their body, that's a tactile hallucination. If this patient thinking that he has the chips in his brain or in his head, right, and he can physically sense it, so that means this patient having tactile hallucination. That was one of the positive finding. And what else? So let's start with the first appearance. We cannot actually comment on dressed appropriate to weather or not. Just say that yes, the patient was dressed appropriate to the weather. Patient was maintaining eye contact sometimes and sometimes not. The important thing is that this patient was looking around the room, which means that he was responding to some unseen internal stimuli. So patient was quite distracted on and off, right, Dr. Dilam? Very good. So patient was distracted on and off, and he kept looking at the different sides of the room, which means that he is responding to some unseen stimuli, which is very important finding. And we always be very careful if there is a video like this, or even if it's a face-to-face where you need to ask questions from the patient, you need to be very careful that on appearance in a psychotic patient, you have to comment that if this patient is responding to some unseen stimuli, and they will be a kind of distracted. Okay, so speech was good. Emotion was not assessed, and you can say by that the mood that I have observed kind of disturbed. Okay, but even if you say that the emotion was not assessed, that's fine. We don't need to go in detail. Perception, in here there was auditory hallucination and tactile hallucination, no visual hallucination. Thought form was linear, no other findings of loosening of association, tangentiality, circumstantiality. Thought content, there was a lot of finding in the thought content. As you can see, patient had delusion of reference because everyone is commenting, everyone is talking about him. That's one of the finding. There was delusion of persecution, which was actually got in the last, right? Patient think that they are poisoning his food. So that's one of the delusion of persecution, which is that if they think that someone is spying on him, that's delusion of persecution or paranoid delusion. The third one, which was positive, is thought insertion, because he thinks that someone is putting thoughts. Now, in here, they actually mentioned some negative findings, that they assessed if there is any thought withdrawal or thought block. I know that I haven't discussed the thought block. Thought block means that if someone thinks that there is no thought left in his mind, okay, it's just totally blank, that means thought block. So you have to say that there is no thought withdrawal or thought block, because it was actually assessed here. So it's very important, this negative finding. And what else? Insight, judgment, cognition was not assessed. You can easily say that this patient is a high risk because having hallucination and delusion. Suicide doesn't only means that patient is high risk. Active hallucination, active delusion is also a part of high risk. So you can say that this patient is a high risk because having of active hallucination and delusion. Then rapport was good, and reliability, it was not reliable. Okay. So yes, thought block, thought insertion, thought um, withdrawal, all are parts of thought content. These are not part of delusion, I would say. These are part of thought content, thought block, thought withdrawal, okay, and thought insertion. There was no delusion of control because he doesn't think that they are controlling him. Okay, so that was really good. Now, remember one thing, in case of video MSc, you have to find all the positive findings because it's easy. You don't need to ask any question. You just need to find out. So usually the examiners are very picky in these cases that you need to find all positive findings. Yeah, only types of deletion are RC, GGP, right? Good. Okay, so let's take a 10-minute break now, and then we'll do some more role play. And whoever wants to do role play, be ready, then we can start very easily. Okay, so 10-minute break now. Thank you all. All right, everyone. So let's start again. Who wants to do the role play now? I think someone at first wanted to do role play. Dr. What was the name? Dr. Tharinda, I think you wanted. Anyone wants to do the role play? Dr. Madiha, please come online. I'll just unmute you. Give me a second. Can you hear me?
Yes, okay. Can you hear
Good.
me?
Yes, I can. All right. Very good. So let's just start the role play. So like always, 1 minute outside and 7 minutes inside.
Okay.
So this is your role play task. Okay. Hi, doctor. Can I check your ID?
Yes, sir.
Yes. So this is your patient. Your patient name is John. You can start.
Thank you very much. Hi, John. I'm Dr. Asif. You're
Oh,
intending.
yes.
Yeah.
Oh, that's really good. Like doctor, doctor, have you noticed today's weather news? Oh, that's perfect. Like the content of the news was done by me. I was doing a good job on the weather, how these things are happening all over the world, the global warming and everything. I'm actually making a thesis on that, and that this is going to be published very soon. And about the nuclear design power plant that I have done, it's amazing. And I'm going to have some the newspaper and also the National Geographic. They are coming to me just to take the interview. How I came up with these sort of ideas, and they're going. I think like they're going to make me a really like one of the biggest scientists in this era. So it's really amazing things happening in around
Yes.
me. Like I'm so much spiced up. This is like everyone gets some good time in their life. I think that this is my good time. And all these
That's
thoughts are
it.
coming in my mind. And I'm so busy with thinking that which one I should take first. So yeah.
All right. So, John, would you please tell me more about these ideas that you're mentioning? They're really great things. So, do you think that all of these things have been done by you, such as there's some special powers?
Oh no, these are all done by me. Like I'm doing one by one. Like I'm going to the thesis part, I'm going to the National Geography, nuclear power plant, the weather. See, all these things are coming in my mind at the moment. It's just amazing.
All right, that's really great. And I want to assure you that whatever you discuss with me would remain confidential unless it's harmful for you or for anyone else. So are you comfortable with me?
Yes, what you want?
Oh, okay. So
I'm really busy, doctor, at the moment. You know that I'm so busy thinking about all these things. I need a lot of time. So if you can just cut short of your question, that will be really great. And I can help you
oh,
with any of your thinking also. I'm really into some of the medical technologies at the moment. So if you need any of the help, just let me know.
Sure, John. I will cut short my conversation and I'll be very quick. So would you please tell me that how's your mood lately? How do you feel in yourself?
I'm good. I'm feeling really great. And I'm feeling like, oh my God, I'm just top of the world at the moment. It's amazing feeling. You just don't know it.
All right, that's really great to know. So do you enjoy your favorite things as you used to enjoy in past?
Yeah, I'm interested in a lot of works at the moment. I'm interested in PCs, nuclear power plant, weather, so lots of things I'm interested now.
All right, okay. So uh, uh, do you think that you have some strange experiences? Like, do you see things that other people can't?
No, why I would do that? I'm not some crazy bitch, all right?
All right, no, John, please don't mind because these are kind of some routine questions. They're kind of written questions that I routinely ask. So, that was just a part of the routine. So, do you think that do you feel or hear anything that other people can't?
No, I just said no.
All right, okay, I understand. And apart from that, do you think that there is someone who is inserting thoughts in your mind or withdrawing them out of your mind?
No, who can do that? I'm making all these discoveries. No one is as smart as me. I'm becoming one of the greatest scientists of this world. So no one can no one can play with my thoughts, you know. I, I'm just having a lot of thinking at the moment. Oh, so good.
Okay, so since when are you feeling like that?
It's been just for 1 week, and I think like it should go on. And I'm just in my life, I'm at the right track at the moment, you know. So good.
Okay, and do you think that someone is spying on you or trying to harm you?
Oh, why would someone spying on me? Some people are very jealous of me that I know because they can't just tolerate my discoveries. So people are jealous of me, but they are not spying on me, I guess.
All right, that's really good. And do you think that anyone is talking about you?
No, I don't think so. But soon there are
Okay,
going to be a lot of talking, I know, because I'm going to make some of the discoveries that world will enjoy for the next generation after generation.
sure, Dr. John. Okay, so do you think that these changes are something recent and they are not part of your normal self?
No, these are why would you say that? Oh my God, so you also don't believe in my theories? The people from the newspaper are coming to take all this thinking from my mind, and they want to know how I came up with these great ideas.
All right, I'm really glad to know. So, do you really see those people and meet those people coming from newspaper and taking interviews?
Sorry, I didn't get it. What did you say, doctor?
Do you really see the people from newspaper coming and talking to you?
No, I know that they're coming. They just contacted with me, then they will come, I know. Yeah.
Okay, all right. And do you think that you need any medical help?
No, why would I need medical help? I'm perfect, I'm feeling good, so why I would need that?
Okay, and so would you please tell me that it's a day today?
Yeah, I think it's Sunday of March, right?
Yeah, sure. And that you get it. And would you recall that where are you now?
I'm at the hospital, doctor. I just need to go now. It's just really important for me to formulate all these things.
Okay, and just a couple of quick questions. That what would you do if you see that there is fire in the room?
Yeah, I will run away, I think.
Okay, that's great. And okay, John, recently did you have any strange ideas of harming yourself or anyone else?
No, why I would do that? I'm feeling great.
Okay, all right. And do you smoke, drink alcohol, or take any recreational?
No.
All right. And do you have good support from your family?
Yeah, but yeah, they don't care about me. That's fine.
All right.
I'm
Okay,
up.
John, thank you very much for this information. Um,
I'm up. All right. No worries, Dr.
would you
Maria.
like
You
me to
did
present?
great. I want you to present. That's fine. So go on.
All right, thank you very much. And so, dear examiner, I'm presenting case of John, who is 20 years old, boy, got by by his parents due to change in behavior.
Just hang on, Dr.
He
Madhya. Your voice is cutting out actually. Sorry to interrupt. Um, have you been using any a headphone or anything?
I'm using Bluetooth. I will switch on to earphone. That
No, that's fine. Just go on. That's okay. I'll try it. It's just cutting off on and off, so it's just going up and down like that. That's okay.
Okay. All right. So, dear examiner, I'm going to present the case of John, 20 years old boy, brought in by his parents due to change in behavior. In his behavior, he seems to be restless, and in his speech is fast and pressured, and also has high volume. He describes his mood to be very high, and he feels at the top of the world, which is congruent with the effect observed. And he doesn't have any perceptual abnormalities or of any hallucinations or illusions. And in thought form, he presented with flight of ideas, and the thought content has delusions of grandiosity. There is no thought disorder observed, and his insight is impaired, and his cognition is intact in 90%, and his judgment is good. I was able to make good rapport with him, but his history doesn't seem to be very reliable due to this active delusion and lack of insight. I would like to take collateral history, and he appears to be high risk due to his delusion and lack of insight.
All right. That's great, Dr. Madhya. You did great, actually. You found out all the important findings. So, yeah, I would say that appearance, yeah, patient was restless, and patient this was actually a very specific case of mania. As you see that just when you enter into the room, you will know this is a mania case. And trust me that mania role player is really good. Okay, it's really good, and it becomes really hard to calm your nerve because that patient will act real crazy. Sometimes he will try to go out of the room. Sometimes he will just run around in the room. So it becomes hard to control your mind also. So in these sort of cases, make sure that you become really calm. And because you see that you will need, like in this case, Dr. Madhya, you will need at least 9 minutes to finish this case, but you just need to make sure that you can finish this case in 8-minute time in the exam. So cut short your history. If you find out your aseptic J3, don't bother, because you will lose a lot of time in the history because the role player will talk a lot. So in this case, don't bother finishing when you know your aseptic J3, just move on to your presentation. It's very important because most of the candidates usually get lost with the history. So it's very important to be in the track. Now you did great. You asked most of the important questions. So appearance, usually you can easily say that patient will be restless, patient might be sometimes running in the room, and they will maintain eye contact sometimes. Then speech is rapid, pressured speech. Then emotion, yeah, you can say patient was very, like patient's told that patient's feeling really good, top of the world. You can use those terms, that's really good. There was no hallucination, that's good. Thought form, yes, that you did a real, like very good point that this thought form is flight of ideas. Good. And then thought content. This patient had delusion of grandiosity because patient thought that he's like smarter than everyone. And obviously, like many a patient has delusion of grandiosity most of the time. Okay. Then no other delusion, I guess. Insight was poor. Judgment was good here. Cognition was good. Patient is a high risk because this is active mania patient. So there is active delusion in this case, and there was no insight. So this patient obviously high risk. Repo, you can say that yes, you were able to maintain a good repo, and the history was not reliable. So you need to take a collateral from the parents. Not important in this case, Dr. Parla, that to know about the depression in mood, because it's just a MSc. If your case is diagnosis and differentials, then obviously you should ask about any low mood to rule out bipolar. Yes, there was one good thing. I just totally forgot. I think I said that I'm quite like people are jealous about me, right? If
Yes.
someone says that people are jealous of him, that should be a delusion of persecution. Okay. Sometimes you can even use the term delusion of jealousy, but I would rather say that delusion of persecution is a good idea when someone say people are jealous of him. Okay, so you did good, Dr. Madhya. Just make sure that you finish it in time. But apart from that, you are doing good. You have confidence because if someone can do many a case, they can do every MSc case.
Thank you, doctor.
No worries. Thank you. I'll just mute you now. Okay, we'll do another role play. So who wants to do the next role play? Dr. Taiba, see that videos of MSc, it's we don't know what type of videos are coming in the AMC exam. Some of the YouTube has some of the videos of MSc which we are practicing now, but in the exam you will get a different kind of video. So it's just about practicing. You can just practice from the YouTube. That's all. But there is no important MSc videos that I can suggest. But all the important video link is actually here uh, with this note. So we will do another video of MSc, and you'll see that what's the difference between these videos. So usually YouTube, I think like there are 4 or 5 videos. If you search the YouTube and write MSc videos, you should get all those things. But again, AMC has its own videos. So you just need to practice and try to find out the things if in the exam you get the videos. Now remember, there is no more critical errors in any case in AMC nowadays. It's just about the key steps. Okay, Dr. Dilam, remember one thing, in case of MSc, you have to find out the positive findings. If you miss positive findings, they can fail you anytime. But sometimes if the role player likes you, if the examiner likes your approach, even if you like miss 1 or 2, they would not fail you totally. So it's a global scoring actually, but you have to get at least couple of key steps. Key steps are the positive findings in this case. Like this, you have to say the flight of ideas, you have to say the rapid pressured speech, you have to say the delusion of grandiosity. This should be found. But if you miss delusion of persecution because it's because patient said at least one time that people are jealous of me. So even if you miss that, they are not going to fail you for that. Yeah. So paranoid or persecutory delusion. So you will include if someone say people wants to harm me, people are spying on me, or people are jealous of me. These 3 things will be included in the persecutory or paranoid delusion. And delusion of reference, Dr. Parla, is that if the patient say that people are talking about me, okay, or they are talking about me. So if someone is commenting on everything that you are doing, you are having delusion of reference. Or if you think people are talking about everything that you are doing, that's delusion of reference. That means people are referring you. And persecution already you know now. Okay. Yeah. Basically, paranoid and persecutory, they are same. You can use any of those two. All right, Dr. Anika, you want to do a role play? Please come online. I'll just unmute you.
Hello, doctor.
Hi. All right, so give me 1 minute, Dr. Anika. I'll give you a case. Okay. So this is your case. Your 1 minute time start.
All right.
Hi, doctor. So this is
Hello.
your patient. Your patient name is Sarah. You can start.
Hello, Sarah. This is Dr. Anika, one of your attending doctor today. So I got to know from the
Yes,
note.
President. I know that I need to come. Yeah, President. I
Okay.
know. Yes, I know
Okay,
that
all right,
you
Sarah.
really need me at the moment. I'm just coming. Yeah, I'm hanging up with this doctor here. It's just getting too
Okay,
late
Sarah,
here,
no
doc.
worries. We're
Y-
gonna discuss about all of your
Yeah,
conditions.
I'm
But before
coming.
that, I'd like to
Yes,
address.
yes.
I would like to let you know that
Doctor,
I'm
can't
Dr.
you see that
Anika,
I'm doc?
one of
Oh,
your attending doctor today.
can't
So
you
can
see
you
that
please?
I'm talking with the president? Yes. What happened, doctor? I'm just talking with the president. You want me to talk with
Okay,
him?
all right. Yeah, we're gonna talk to you. But before that, can you please answer me some of my question? Can you please tell me about your mood nowadays? How is your mood
I'm
nowadays?
really I'm really in a hurry, doctor. I just need to save the world, and I need to get
Okay.
into the flight at the moment. It's just getting delayed for you. I need to go to the flight. I need to go to the UK at the moment, and president needs me. It's really
All right.
important to save
So,
the world.
can you please tell me, do you feel sad anytime?
Why I would feel sad? I need to go to the UK. The president is waiting for me at the moment.
All right. So, can you please tell me about your sleep and appetite nowadays? Do you have any difficulty in sleeping?
I don't want to even think about sleeping when the world
All
is
right.
in war, doctor.
Okay, that's all right. So, can you please tell me that do you think the life is worth living, and do you ever thought of harming yourself or anything like that?
No, I want to save the world. Why I would
All right.
harm me
All
or
right.
others?
Okay, Sarah, now I would like to ask you some question which may sound so weird to you, but just don't get offended. All right. So can you please tell me, can you see or hear or feel anything that other people doesn't?
I don't know whatever you were talking about. I just know that the president wants to talk with me, and I need to go
All right.
to the. I need to go. I need to go now.
All right, that's all right. Can you please tell me that someone is trying to harm you or trying to spying on you, anything like that?
Who can harm me, doctor? I'm the greatest magician of the world, and that's why
All right,
I'm
all
the only
right.
one who can
Okay,
save this
okay.
world.
So do you think that someone is trying to put some thoughts into your mind or trying to take it away from you, anything like that?
No one can do that, doctor. I just said I'm the greatest magician.
Okay, that's all right. So can you please tell me that do you know where you are right now or what's the time today?
Yeah, I'm in the hospital. I just need to go to the airport at the
Okay,
moment. It's
okay,
really
okay.
important, doctor.
I will just ask you some little bit more questions. Can you please tell me that suppose this room isn't just fire, so what are you gonna do about that?
I'll just put off this fire. Fire cannot touch me. I'm the
All
magician.
right,
No
all
fire
right.
can touch me.
Okay, so do you think that you need our help?
I don't need anyone else, but president
All
needs my
right, all
help, and
right.
you are just making me
Okay.
delayed.
No, I would ask you some little more question. Do you smoke or drink alcohol, or do you have enough support from your family?
I don't have anyone and I don't need anyone. I just want to save the world. That's all I want.
Okay, Sarah. Okay, don't worry, we're gonna help you on that. All right. So, okay, thank you so much for all of your information. Now, examiner, I would like to present the MSc of my patient Sarah, who was previously diagnosed with schizophrenic disorder and didn't take any kind of medications. So, regarding the appearance, she was very restless and she was not very much comfortable. Cooperative with me, and she was not regarding the eye contact. I cannot comment on that, and the speech was very rapid and pressurized, and it was not slow or monotonous, and in the emotions, according to him, was all right, and the effect that I have found was not congruent with the mood, as was congruent with the mood. And regarding the thought form, it was not linear, or there was no tangentiality or circumstantiality, or there was no flight of ideas, but there was loosening of association was there. And regarding the thought content, there is no auditory or visual or any kind of tactile hallucinations, but he thinks that there was a delusion of grandiosity was there, because he thinks he is the greatest. And regarding the inside, it was poor as well, and regarding the judgment, it was also poor, because he thinks that he doesn't need any kind of help whenever if he is in the room with fire. And regarding the orientation, he was oriented with the time and the place as well, and he was maintaining a not good rapport with me, and there was a risk, because there was a risk of the suicide as well, because there was a risk because there was some active delusion was there, and he was not maintaining a good rapport, and the history that was given by him was not reliable. So I need to take some collateral history from the parents as well. Thank you so much.
Thank you, Dr. Anika. It was really good. You finished like I've done role play with a lot of candidates. Never ever since in like you still got 1 minute 20 second. Okay, but
Actually, I was shivering.
yeah, I can't find it out. But remember one thing. I know that you are running out of time, but like again, not too fast, not too slow. It should be in the middle. You did good. But the important thing which the examiner will say that there was a lack of attachment with the patient. You have to. Now I
Okay.
know that these are very important, like hard. These things are hard to get it, because you are running out of time, and when you see that there is a task of psychosocial history, which means you need to take more history than just a MSc, then you think that, well, I need to run first, and running is all right, but obviously that you cannot interfere when patient is talking. It's really important. I know that I was talking a lot, or the patient will talk a lot, but still let them talk. Don't interfere that when they're talking. It's important. I know that like our mind thinks that, well, just stop, man, stop. So, but
Yeah,
still you can,
right.
but you cannot say it to the patient, or you cannot show it to the patient that, well, stop it. I just want to talk. So don't do that. It's important to hear the patient rather than asking a lot of questions. So always hear what they want to say, because if you would hear me, you would get more positive findings. Okay.
All
So
right.
because
All right.
yeah, it's important,
So,
really
doctor,
important.
if there is if there is a task for the psychosocial history, suppose in case of depression or schizophrenia or whatever the case is, so in that case, like, do we need to take lots more? History regarding that case. I mean, not only just maintaining the psychosocial format, the history format, but
Yes.
rather than we need to add some more history over there, right?
Yeah, that's thing. Like because in this case, you need to ask the patient that, well, I know from the notes that you had diagnosed with schizophrenia from disorder. Can you please tell me more that when you have been diagnosed, and is there any reason why you are not taking the medication? How long you are not taking the medication? Okay,
All
just a
right. All
couple of
right.
questions based on the stem.
Okay. Okay.
Okay,
That's all.
and also like you can like your you need to ask about sadma, like smoking, alcohol, recreational drugs. You need to ask a question about the home situation a little bit, and the work situation a little bit. And is there any past medical history, past mental illness, and family history of mental illness? Just 5 6 questions you need to add apart from the MSc.
Okay, all right.
Good thing is that in here there is no diagnosis. If there was a diagnosis, then there will be a lot of questions, because you need to diagnose this condition. So you need to ask how long this is going on, when this is started. So to diagnose a condition, you need more questions. Like in depression, you need to add MSIH caps. In mania, you need to add big first. So we'll discuss all these things. So you need to add questions if there was a diagnosis, but there is no diagnosis. You don't need to diagnose it, but you need to ask psychosocial question fully. That will include your heads, SADMA, all those things.
All right.
Okay. Let's just start. Say that what else we can do. So important, Dr. Anika, make sure that your confidentiality statement, I know that you were giving confidentiality statement, but I was talking at that time. So maybe that I missed that part. Okay, it can happen because the
Okay.
role player are designed in a way that they will do in a specific way in front of you. Like they will start talking with the president and they will pretend that they're talking with a phone in their hand. Okay, by that time, you should understand that this patient having some hallucination of auditory hallucination, right? Because there is no phone, but patient is pretending to talking with someone, which means this patient having auditory hallucination. So
All right.
normally what is good way that you can start asking question from that. Can you please tell me who you are talking with? Because if you don't, then you miss totally that part, that who I was talking with, and is the president, like can I see the president, or do I just hear him? Okay, is the president giving me any command to do anything else? So these are the questions which we need to find out from this patient. So you can start from that and then come to your format of mood, sleep, appetite, all these things. That's a good way.
All right, doctor.
Okay, good. Now, in this case, patient's appearance, in here, what will happen? You will see patient will be quite distracted and restless, and patient will be like, patient pretends to talk with someone holding a phone in their hand. Whatever you see, you will just comment on the appearance. Speech in here, you can say patient speech was loud, but there was no disorganized speech. There was uh, no slow monotonous speech. Okay. Emotion. What did you say about the emotion?
Actually, I was saying that she was restless, and the effect that I have found was congruent with the mood.
Okay. What I said about my emotion, I totally forgot. I think I said that I'm okay or something, or maybe I don't remember what I said. So in the emotion, you need to say that what I said when you ask how is my mood, okay? And then you can say anything about the affect. Then perception. In the perception, was there any hallucination in here? Yes, there was auditory hallucination, which you missed. And there was no visual or tactile, okay? And what else? Thought form. Thought form in here, remember, if I am answering your questions appropriately, my thought form is linear. My thought form will
Okay.
have loosening of association if you cannot understand what I am talking about. Like it's just a nonsense talking. Okay. But still I'm talking, like whenever you are asking question, I'm answering it, right? But I'm not just like talking nonsense. I'm answering your questions appropriately. So in that case, you can say that my thought form is linear. There is no tangentiality or circumstantiality.
All right, doctor.
Yeah. And then what else we got? Thought form, thought content. Thought content is mainly on the delusion. So this patient had a delusion of grandiosity. Okay, as you say, that was good. And was there any other delusion? I can't remember. Guys, did you remember any more delusion I said? No, I think I haven't said any more things. So, and you didn't ask much. So you have to ask, like, do you think someone is controlling you? Do you think people are talking about you? So if you ask, then you will get more findings. Then insight was poor. Cognition was okay. Judgment was poor, I think. And this patient is a high risk because patient having active hallucination and delusion. Rapport was not well built because patient was quite angry sometimes. And reliable, it's not reliable. Okay, and you need to take real what was that? Collateral history from the
Collateral
parents.
history from the parents, right?
Yeah, good. All right. So that's mainly all the positive findings. Let's see that what else are the others thinking. No, Dr. Sujan, it was not, he was, yes, Dr. Sujan is right. So he was talking to the president. He is not the president. So that was the auditory hallucination. Why thought broadcasting was there, Dr. Jinath? Dr. Parla, no loosening of association. Loosening of association means that whatever I am talking, I'm not answering your questions at all. Whatever I'm talking is total nonsense. That means there is no association of each of my sentence that I am talking. In the exam, most likely there will not be any such case because they will answer your questions. Yeah, in this case, Dr. Dilam, if patients say my mood is normal and acting crazily, like how I was doing, you would say patient emotion, like in terms of emotion, patient says his mood is normal, but the affect that I have observed was disturbed. But you did good, Dr. Anika, I would say, because you were first and you finished the case first time. That's also important. You just need to make sure that you don't get too fast. Just give some time for the patient. Don't think about the time too much. You should be fine. Okay. Because most of the candidate they run out of time, and you had time. So now you can manage, like you had at least 1 minute 30 seconds. So 1 minute 30 seconds is a lot of things. You can add a lot of things in this time. So Dr. Sultana, very good question. Patient think that he's the greatest magician, right? That means patient having delusion of grandiosity. And the same, like power to stop the fire, that means patient doesn't have a good judgment. And same thing, the patient have this grandiose delusion. Thought form will be linear. Now, important, if someone says that people are going to take my ideas, that doesn't mean patient having active thought withdrawal at the moment. Okay, that will not be included. If I think that at the moment my ideas are like someone is withdrawing ideas from my mind, that means I'm having thought withdrawal. But if I say, well, i'm 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 making the greatest discovery at the moment, and in the future like people will take my ideas, that doesn't mean that patient having thought withdrawal. The affect disturbed means that, see that this is a psychotic patient, their mood cannot be normal. Their mood is always disturbed. Because if he's thinking that he needs to go to the airport, he can put out the fire, he is the greatest magician, so how come his mood is normal? Right, obviously he is disturbed. Cool. We will finish here tonight with just one other video. I would advise, if anyone wants to do it, but I will not ask someone from my course, because we already took the class in the course and you guys already know the video. So not from my course, anyone from outside the course wants to do a video case? Anyone? Any new apart from Dr. Parla? Dr. Parla, you will do good in this case. You don't worry on that. Okay. I want to see if there is any new one. I always want someone new doing role play, making themselves comfortable. If you can do role play in front of 50 people, in the exam, there is just one role player, one examiner who is not talking at all, and there is another invigilator. So in front of 3 people, that it will be just a nothing. Any new people wants to do a video role play? Just a video MSc? No one? Okay. All right. So Dr. Parla, I think you're in luck. Let's start. See that I'll unmute you. That's fine, Dr. Muniba. So it should be fine. All right, Dr. Parla, let me give your case. Okay. So same like how we did previously with Dr. Lin, I think.
Yep.
So you ready? I will just start the video.
Yes. Okay.
Hello, Robert Smith.
Yeah.
Thank you for coming to see me today. I'm Dr. Stanley. I'm one of the doctors that works here. Obviously, anything that we say is confidential between us and the team that I work with, and your GP who's asked me to see you.
Okay.
I hear there've been some problems with your housing. Do you want to tell me a little bit about them?
Yeah, I've had all sorts of problems. I mean, where do you want me to start? My neighbours, police, people spying on me in my street. None of them will admit to it, but my neighbours, it's mainly them at number 9, but I've seen them talking to the ones at number 6 and across the road as well.
So when did things start to go wrong?
I don't know. I mean, you'd have to ask them. Well, like when they started properly, like deciding that they wanted me out of the street. I think it was a few months ago. Months. It's been going on for months.
What makes you think they want you out the street?
Well, it's the harassment. It's the spying on me, putting bugs in my house, in my phone. And that at first they thought I couldn't hear it, but now they know that I know that they're there. Saying things about me through the window. Talking about what I'm doing. I know they're doing it. Whenever I leave my front door, woman at number 7, she's always there. She's clocking where I'm going and what I'm doing.
Why do you think they're doing that?
Well, I don't know. They're just. I think they want me out.
Mm-hmm.
I think they're testing me, and they're trying to find out how far they can push me. Basically, it's all part of some test. I don't know why. I don't know what for. You'd have to ask them. That's what I've said to the police time and time again. I've said to them, why are you asking me these questions? Why don't you just talk to them?
You said that your phone was clicking. What was that about?
A landline.
Your landline?
Yep. Somebody rings me or I ring somebody. Between 7 and 10 seconds in, I hear click, click, click. Click, click, click every time.
Any other explanation for that?
I don't know. Well, it could be, but every single time, and then they're talking to me, and then they know what I've been saying down the phone.
How are they talking? Where are they talking to you?
Well, I can hear them next door. Oh, he's on the phone again. Oh, he's reading that book again. I can hear him saying it. and they know that I can hear them, and that's why they're doing it.
Okay, so just to summarise at this point, your phone's, something's happening to your telephone. You can hear your neighbours talking about what
Yep.
you're doing, making a commentary on your actions.
Every day.
Every day, and you feel that there's some sort of reason for all their actions doing this. Any other things that you've got problems with?
Following me down the street. People following me when I'm going to the shop. You know, it's happening more and more. It's happening more and more. I mean, I've tried to explain to my friends about it. They get really agitated. They think I'm off my rocker, but they don't see it. You know, they're not living with it every day.
Okay.
You know.
So your friends are worried as well?
Yeah.
So
Well, worried, or I mean, I don't think they're on it. I don't think, but they know a lot about what's been going. I don't know. Maybe the police have been talking to them or something, or maybe my neighbours have been talking to them.
Okay.
I don't know. Again, you know, you'd have to ask them. But you know, it's hard to know. It's hard to know who to talk to, because they all, you know,
So
they're all involved.
So this started happening a few months ago. Has it had any other effects on your life?
Well, yeah.
Such as?
Can't really go out. Well, I can, but I know what's going to happen if I do. So I'm just trying to stay low key. You know, I'm trying to stay out of people's way. You know, I've hardly slept. I've hardly slept for the last, I don't know. I can't remember the last time I got more than 4 or 5 hours sleep.
So what disturbs your sleep?
I don't sleep until, I don't tend to go to sleep until after 2, 3, when I'm sure that they've turned everything off.
Right, okay.
You know, downstairs, and just can't, you know, I'm worried about it.
Any problems watching the telly, listening to the radio?
Oh yeah. They're using the TV as well. They're using all. They've got all this technology, obviously. I mean, I know there's all these smartphones and whatever now. You know, all they need is one of them, and they can just. But yeah, TV. You know, they've got the local news. If ever I watch that, you know, there's always some little comment. There's always something they say in there at the end about what's been going on. You know, pretty much every time I turn the TV on now.
Okay.
I mean, it's it's all just the cable, isn't it? So they could, for all I know, they've just plugged it into that.
What do you mean the cable?
The cable TV. You know, it runs down the street. You know, everybody's got access to it if they know what they're doing. You know.
So obviously, this is all very distressing. All the different things that are happening. Can I take you back a little bit and just find out a bit more about you? I think your doctor said you're age 29.
Yeah, 29.
Yeah. Tell me a bit about where you were born, your upbringing.
All right, doctor. So that's your MSc video. You will get 2 minutes time to present the MSc.
Yeah, I think I'm good.
Yes, let's start.
Okay. So this gentleman is 29 years of age. He presented to our clinic after he was advised to by the GP. In terms of his appearance, he seemed to be well groomed and dressed appropriately. He was cooperative. He did not maintain eye contact all the time, so it wasn't really consistent. He was a bit agitated and restless, and he seemed distracted at some times. His speech was rapid and pressured, and at some times it was disorganized. In terms of emotion, his mood was disturbed because he was always talking about how angry he was and how upset and worried about his neighbors, and so it was disturbed, and the affect was congruent with his mood, because that's what I observed. He looked distressed and angry. His perception was abnormal because he was having auditory hallucinations. So he was hearing his neighbors talking about him, and he was hearing the clicks on the phone. And in terms of thought form, there was flight of ideas, kind of, but there was no circumstantiality, no tangentiality, and no loosening of associations. In regards to his thought content, there was delusion of persecution, because he thinks that the neighbors are spying on him, talking about him. There was also what's it called? Thought broadcasting, because he thinks that his thoughts are being broadcasted on TV. And in terms of cognition, that was not assessed. Insight and judgment were not assessed. In terms of risk, I consider this patient to be high risk because he's having active delusions and hallucinations. And in terms of rapport, it was quite good. She was able to communicate with him, and the history was not reliable because the patient seems to have delusions and hallucinations. So I would rather get some collateral history from witnesses, from his friends, or from even the police.
All right. Very good, Dr. Parla. You did really great. I would say again, it's good that you found out most of the important things. Okay. Now, what else we can add or delete here? So appearance was good. Then speech, right? In here, like, don't say disorganized speech. Disorganized speech is mainly like someone, the same thing. Like if someone is like talking totally nonsense, you cannot understand what they're actually talking about. Now in here, you know that the patient is upset about the neighbors. You can totally understand him, right?
Yes.
So this patient's actually not having any disorganized speech. The speech is totally fine. So
Okay.
it's just, you can say that patient speech is sometimes loud, but most of the time it's normal in tone, volume, and rate. Emotion. You commented on emotion. Remember one thing in here, you can just say that emotion was not assessed, but the effect that I have observed, it seems like disturbed. In this way, if you say that, it becomes more better, I think, because emotion actually, they need to say that how is your mood. If they say that and patients say I'm feeling low or I'm feeling all right, then you can say emotion is low or normal. But if it is not assessed, you can just say that emotion was not assessed, but the effect that I observed was disturbed.
Oh, okay.
Okay. Then what else? Perception. In here there was auditory hallucination. And then thought form is linear, thought content. In this case, this patient having persecutory delusion because he thinks neighbor is spying on him. Patient having also delusion of reference. That was missed actually. If a patient thinks that people are commenting on him, people are saying everything, or people are talking about him, always say delusion of reference. Like that's also a delusion of comment. That's a part of deletion of reference. Usually don't use the term deletion of commentary or something. Say that if you see that they're saying that people are commenting on everything I'm doing, that will be included in the deletion of reference.
Okay.
Okay. And yes, this patient had thought broadcasting also. Then inside judgment cognition was not assessed. This is a high risk patient because of active hallucination and delusion. Then rapport was well maintained between the doctor and the patient, and the history was not reliable. You say that you want to take a collateral history, always say that use a third person here because you are not the doctor in this case. So say that the history doesn't seem to be reliable, so it would be a good idea to take a collateral history from the patient's neighbor, friends, or relatives.
Oh, okay. Yeah.
Okay.
Thank you, doctor.
Good. No worries. It was really good, Dr. Parla. Keep it up.
Thank you.
Thank you. All right, guys. So I hope that this class was helpful for you. This is a really important session. And when you know more about these cases, you will understand that how important all these cases are. So I would advise all of you to practice this sort of role play with your partners. Make yourself acquainted with the situation. Make yourself feel like the exam environment. If you don't do role play, remember one thing, you may think that you know all the format, but when you will do role play, you will see that it really matters, that when you need to do a much more practice with others to get the format in your head. Okay, it's very, very important. There was no visual hallucination in here because like patient can see neighbor in the street. It was not actually clear that how it was, but patient did not say something like that and it was not assessed in that way. So don't say that as a visual hallucination. No, Dr. Taiba, in perception, you assess only hallucination. In thought content, you assess delusion. So deletion of reference is a part of thought content. So that's why I said, first go to the MSc video that we have, like MSc class that we have taken, then do the role play, because I know that like it's quite confusing, but we discussed everything about this thought content, delusions and everything in our first class. Please go through that, Dr. Taiba, you will get it. I can say that it's very, very well discussed. But if you really want to know, then thought content includes all the delusions, which means the delusion of control, delusion of persecution, delusion of reference, all are a part of thought content. Yeah, Dr. Madhya, very good point. It was not a flight of ideas, Dr. Um, Parla. So remember one thing, flight of ideas only present in mania case. So I know that sometimes you can get confused because patient can go from one topic to another, but remember that the whole case matters. This case was mostly schizophrenia. So very unlikely this patient will have a flight of ideas. Flight of ideas was the mania case. You say you've seen the role play. So I was just talking about a lot of like weather, nuclear plant, thesis, national geography. So I'm just jumping. So if you see something like that, then only talk about flight of ideas. In here, you can say linear. Paranoid and persecutory delusion are same, Dr. Cookie. So if you, yeah, spying on him will be included in here. Good. Okay, so that finish our today's session. You guys remember one thing, that we are taking 2 weeks free session starting from, I think from the next week or so. So maybe from the 23rd of March. So keep an eye on our group. I already uploaded the full 2 weeks free session schedule in First Aid AMC Clinical, as well as the new Facebook group where we are giving all the recordings of these classes. So make sure that there is two tasks. Make sure you, even if you don't want to join the course, make sure you get some benefit from this 2 weeks free session. At least you will know how to deal with the cases and how to start your preparation. So do that, join those classes, and feel free to communicate with us that whatever problem you are facing, and we'll be here with you to find out what's your problem and how to deal with that. There is a lot of change happening with the exam at the moment, as you guys know. So don't worry on that. We will deal with that. We dealt previously, and people used to pass from this course previously, and now they will, again, people will start passing. So there will be always a way. Don't worry on that. Believe in what you are reading, what you are practicing, and keep your eyes open. Okay, your eyes and ears should be open when you prepare for AMC Clinical. It's very, very important. We don't have any specific physical examination online course. We usually include it in our course. Okay. Yeah, Dr. Thomas, all these videos are usually uploaded not in our First Aid AMC Clinical official group. Usually I upload it in our new Facebook group. I will again update the link of that group, because what happens is that usually if I just upload these videos in the new group, then only the interested people who usually need it, they will get it. Okay, it's not a good idea to post this to a whole lot of population. Okay, so always better to make it safe and secure. But the videos already, the cardio videos will be posted. Every video of this free 2-week session will be posted in the new group. It's called, I think, First Aid AMC Clinical Online Best 3 free 2-week session, something like that. It's a big name. So Dr. Shirisha, yeah, that's a good thing you say that, yeah, it would be a good idea to start a PE course according to the new format. Now, I don't want to talk about it at this time. Why? Because we don't know the full format. At least like when 2 months will be gone, then we will know much more better way that how this exam, the physical examination things are coming up. Okay, then we will think about that. The previous course student, you guys will be always updated. So if you like, we will update the basic thing obviously for you. And if even if you want to like join our new course sessions, there is always some way. Please message us in the Facebook or in our email. We will discuss about it. Okay, thank you guys. It was good to do a lot of role play with you. It was very spontaneous. Okay, we'll see you in the next session. It's a whole course, Dr. Taiba. There is no like only one system at this time, because usually we add you to the software, and our software is designed in a way that you will get everything when you join the course. So we can't actually add just a specific person to a specific system at this time. Okay. All right, let's see that what happened in our Facebook group. I I haven't looked into that actually today. Let's see if there is anything. Mhm. Not much, no, not much question actually. How we comment on perception? Can we say perception was abnormal? Dr. Gina, you can always say in terms of perception, there was no auditory hallucination, visual hallucination, or tactile hallucination. If anyone wants to join the course, the 5 months course, always feel free to message us in our messenger. You can always like, yeah, you can send us a message in the messenger with the admin Dr. Arshan in that name. And also you can email us to the first aid AMC 4536 at outlook.com. All these things are included in all the posts that we are giving in our group. You can email us, you can message us, just let us know that you want to join, and then we will give you the next procedure. Thank you, everyone. Have a great day. Bye. We'll see you in the next session.